Okay, dear students, Assalamualaikum warahmatullahi wabarakatuh. So for today's lecture, I will cover mental disorder 2. Although this topic has been covered by some of the groups according to the sections, but I would like to emphasize that certain topics will come out in the exams in the form of MCQ as well as MEQ. So I hope all the students get a chance to listen to this asynchronous lecture, yeah, for the sake of taking exams. So first topic that I will cover is the schizophrenia and related psychosis. So while giving this asynchronous lecture, I will also provide some hints and the topics that may come out in the MCQ or MEQ, yeah. So what is a schizophrenia? Uh, So, it is very important for you guys to differentiate schizophrenia and other related psychotic disorder uh, according to the duration. Because in the ward later on, when you go to clinical posting, you may encounter a diagnosis of brief psychotic disorder, schizophreniform, and there are also schizoaffective disorder. So it's a shame that if you don't know what is it. So in this lecture, I will briefly inform and certain diagnosis like maybe schizophreniform, schizophrenia, brief psychotic disorder. You need to choose the correct diagnosis according to the durations. But don't worry. So by listening to this lecture, you will be able to differentiate what is the difference between brief psychotic disorder, schizophreniform, and schizophrenia. I believe all of you already know what is schizophrenia based on the presentations, like those with hallucinations, especially the auditory hallucinations, visual hallucination, with the disorganized speech and behavior or delusions. So you know that is schizophrenia. However, when the symptoms uh, presented by the clients is less than 1 month, for example, in 1 day or 2 day, the person experience auditory hallucinations. So it is called as brief psychotic disorder. Okay, according to Diagnostic and Statistical Manual of Mental Disorder, it is called as brief psychotic disorder, and the psychiatrist may give this diagnosis according to the duration presented by the clients. And if the duration is between 1 month to 6 months, but not more than 6 months, it is called as schizophreniform disorder. Okay, so those who presented with the symptoms of schizophrenia, especially the deterioration of functioning as individuals for more than 6 months, then we can give the diagnosis of schizophrenia. Okay, I hope it is clear about the duration. However, there are also a diagnosis called as schizoaffective. Let me use my pointer. So, schizoaffective disorder is a disorder, it is similar to bipolar mood disorder, but here the presentations of schizophrenic features like auditory hallucinations uh, or delusions is a mixture of between schizophrenia and mood disorder, but it is not exclusive to the mood disorder like bipolar mood disorder in manic phase. Yeah. So schizophrenia, the prominent feature belongs to more to schizophrenia patients with the deterioration of functioning. And there's a little presentations of the mood features, for example, being elated, being happy, or being depressed. But it is not suitable to put the diagnosis for major depression, for the depressive symptoms, or manic symptoms. Yeah. So we need to differentiate what is schizoaffective, what is bipolar mood disorder, and major depression. Yeah. And number five is the disorder which exclusively for people or individuals with only thought disorder or delusional disorder, which is the false and fixed belief, but they are not presented with the hallucinations, with the problems in speech or behavior. They just have the delusional thinking. And the last one, which I already covered in the previous lecture, is about substance-induced psychosis, which also belongs to the psychotic disorder. So we move on. The important characteristics of schizophrenia is actually that they need to have this positive symptoms, two positive symptoms for at least 1 month duration. And schizophrenia, the durations of the problems in the functioning happens for longer than 6 months. Okay, so at least for 1 month, they are actively presented with having hallucination, especially the auditory hallucinations, or they can also have delusions, such as persecutory delusions, disorganized movement which is hard to control, or there's a repetitive movement which is can be observed from patients with schizophrenia. For example, they may have some habitual movement, like they keep on pointing over here, or they keep on tapping over here and there. Is quite similar to autism, but not all schizophrenia patients have disorganized movement. Okay, or maybe for certain patients they have the negativism in their movement. If we ask them to walk forward, instead they walk backward. Okay, that is negativity in terms of movement. And they also have a confused thoughts and disorganized speech, which we can observe from their statements or whatever that they say. There's a lack of associations between one sentence to another sentence, because they are very disturbed in terms of their hallucinations, so they tend to talk according to their hallucinations. Yeah, so there's a lack of associations between one sentence, or we cannot see the coherence in the story that they tell you, or they may say something which is not realistic, yeah, because they're confused. uh, and some of the old patients, schizophrenia patients, if they are affected with schizophrenia for about maybe 10 years, okay, they just have the negative symptoms. For example, social withdrawal, like they don't know how to mix with other people, they have trouble or difficulty to express words because it becomes their habit for not talking to everyone else, and due to their deterioration of functioning and social withdrawal, and they have a lack of pleasure to get involved in the society, to go to the uh, to go for a picnic, to involve in pleasurable activities such as go to cinema, karaoke, and so on. And they, from their facial expression, you can see that there's a lack of emotions presented, or flat effects is actually the facial expression which is similar to showing no emotion. Yeah, so this belongs to those who have been affected with schizophrenia for over a long duration, especially the old patients. And we also have a cognitive symptoms and also thinking problems. You need to remember that those schizophrenia patients, they will have problems in their executive functioning. So, for example, if previously they can count using mathematics and make a rational or difficult decision making, but due to schizophrenia, and like I said, they will have a deterioration of functioning for over than 6 months. Okay, so problems with executive functionings include poor memory. They are not able to memorize before the onset of the illness. They also have lack of attentions due to uh, being in their own world of listening to hallucinations. That's why they cannot focus or pay attentions. They have disorganized thoughts, and also they are poor in decision making skills. Yeah? So this is the cognitive symptoms. And I would like to emphasize on what is paranoid schizophrenia. Sometimes patients, you see that this patient may not have schizophrenia, but when you start talking with them, uh, you they start to share the content of hallucination which they think they are the other persons or the family members have a bad intention or want to do harmful uh, things to him or to her. That is persecutory or paranoid. Yeah? So these paranoid schizophrenia patients, they sorry, they don't have much problems in terms of executive functioning or speech or movement, but it's just that their hallucination, the content as well as their delusions, which is the false and fixed belief, is very strong. Yeah. So this is paranoid schizophrenia, which we need to differentiate and provide nursing care in a careful manner. Yeah. So move on to the psychiatric management. I don't want to touch so much on the schizophrenia because I believe that most of the students are familiar enough with this diagnosis. So for the psychiatric management, I think this topic of psychotropic drugs has been covered extensively by Sister Ramla. So I just would like to mention few drugs which is commonly prescribed to schizophrenic patients. For example, chlorpromazine, or in short, the nurse always calls CPZ, CPZ in short or in abbreviations. And we have fluphenazine, haloperidol, propanazine, theoridazine or Mallory, the trade name. So these antipsychotics or typical drugs, they are the old drugs, but if the patients in the earlier stage was prescribed with these drugs and they can tolerate the side effects of the drugs, that's why the psychiatrist will continue the same prescription, although they are old drugs or they are antipsychotics. But the patients can tolerate, and there's no side effects presented by the patients. So it is best for the psychiatrist to just continue with these drugs because we would like the client to comply with the same drugs. So if the client produce certain side effects due to haloperidol, for example, if the patients starts to show Parkinsonism or acute dystonia after taking haloperidol, then we need to change to other drugs. Okay. And also we have atypical antipsychotic, which is the new drugs. We have clozapine, olanzapine, aripiprazole, paliperidone, or nowadays we have the injections of Trinza, Invega Trinza, which actually in the form of tablet. We call it as paliperidone. We have Seroquel, Risperidone, and Ziprasidone. These are all new drugs which are commonly prescribed by the psychiatrist. Yeah? And also for the injections, for example, like paliperidone Invega, uh, it is still prescribed in a monthly basis. So let's say the patient has their tablet and they take it orally. But let's say if they skip the dose, they due to these injections, it can manage their symptoms. Although they skip the oral tablet on the certain days, yeah. So it is very effective to manage schizophrenia nowadays. So that's why in the present times, it is very rare for you to see those schizophrenia patients who are chronically ill. Unless they don't come for the follow up, they have poor family support. Okay, that's the chronic schizophrenia. But otherwise, those schizophrenic patients, when you see them in the ward or in the outpatient setting or in the rehabilitation setting, they are quite stable. Yeah. Okay, and we also have psychotherapy like individual therapy where we allow the client to talk based on one-to-one basis. We have group therapy where we can provide some topics, for example, coping with stress among patients, so they can discuss about these topics and provide their way of coping with stress, for example. And we also have cognitive behavioral therapy for the psychologists to correct their thoughts on certain behavior, and also we have cognitive enhancement therapy. So for the nursing diagnosis, here I would like to emphasize on the disturbed sensory perception, which is due to hallucination, especially the auditory hallucination, which is commonly presented by the schizophrenic patients. And you can observe this through patients talking to himself or herself, or laughing to himself or herself, which is alone. When they are alone, they have this TTH, or in short, or uh, talking to himself or herself, or LTH, laughing to himself or herself. So our goal is for the patient to be able to define and examine their reality, because they are always in their own world due to these hallucinations, delusions, and we like to reduce the occurrence of the hallucination by bringing back the client to reality. So first thing is, first we need to build rapport as to establish a trusting relationship. Number two is we need to assess or monitor the patient's signs of hallucinations, for example, like talking to himself or herself, laughing to himself or herself. And number three, we need to avoid touching the client because the client are in their own world, and they may become startled, like terkejut or shocked if suddenly you tap bang tap them from the back. Yeah, they may perceive it as danger. So client may interpret this with threat and respond in aggressive manner. For example, and especially for those paranoid schizophrenia, mm, they may be difficult in terms of to build a trusting relationship with the nurse. And also it is very important for us not to touch this patient, or maybe we need to stay away with these patients. Yeah. And number four, we need to encourage the patient to tell the content of hallucinations, because we would like to know what are the contents. Let's say the content inform the clients to injure themselves, to harm themselves, or provide some comments like to harm the other patients or the nurses. Okay. And number five is we would like to provide positive reinforcement if the client can differentiate between reality and hallucinations. Positive reinforcement refers to any compliments, like we can praise clients for good behavior if they can differentiate between this is auditory hallucination. So we can give some things in the form of rewards for the patients in order to reinforce uh, their awareness that this is hallucinations, and they need to focus on the real situation or their task. That's example of positive reinforcement. Number 6, bring the client to reality by involving in activities. Or also we can also involve client in reality orientation. Like we need to remind the client about the time, the place, and the persons. And number 7, teach the client on the symptoms of hallucinations, delusions, which is part of the schizophrenia, so that they know this about the signs of relapse later on. And lastly, administer medication, for example, tablet chlorpromazine as prescribed by the doctor, which is to minimize the symptoms. And our evaluation is that the patient is able to define and examine reality, reducing the occurrence of hallucination. So here, let's say if you forget about the nursing interventions, uh, at least you need to remember, first thing, you can get 1 mark. Like simply you get 1 mark if you provide build rapport with the patients. And then number 2, assess or monitor. Okay. And then number 3, if you forget, at least you put bring the client back to reality or involve the clients in activities, and don't forget about administer medication. So at least if you cannot remember about certain things, at least you can simply get 5 marks with the rationale. Okay. Second in diagnosis is impaired verbal communication related to altered perceptions as evidenced by difficulty communicating thoughts verbally. So our goal is for the patients to express thoughts and feelings in a coherent, logical or goal-directed manner. So for the nursing interventions, you can read this on your own. Okay. Okay, and then for the psychoeducation, it is very important for you guys to provide psychoeducations later when you go to the hospital during your clinical placement, because uh, for the patients before they go back to their home, okay, it is very important, especially to those first-time patients and the family members, to understand what is schizophrenia. So, what are the symptoms? What it affects? Like, this schizophrenia affects the person's thoughts process, the mood, emotions, social functions. So, we need to emphasize this and to let the patients and the family members be prepared about what to expect after the patient is with them at home. So we also need to explain to the patient and the family members about the importance of medication compliance and the side effects of medication. So the importance of medication compliance is because once they default the treatment, default means they skip for not taking the medications, they skip the follow-up, the relapse symptoms will cause another admissions, which can also further deteriorate their functions in the community, or their role in the family, or their role as a worker. Okay, so they will lose a job later on. So it affects a lot of things if they readmitted again and again. Yeah. And also we need to explain about the side effects of antipsychotic, especially the extrapyramidal symptoms such as tremors, muscle stiffness, restless, and rabbit syndrome, which in the form of layman term. So by now you should be able to know the terminology of EPS such as Parkinsonism, acute dystonia, akathisia, and also tardive dyskinesia. But for the psychoeducation purpose to provide teaching to the client and family members, you should be able to inform in a layman term, not using the medical terminology. And we also would like to educate the family to monitor about the medication intake by the patients. So it is preferable if the family members can supervise closely, know where is the medications, and also count the medication. Yeah, that is very important. Uh, and also, we like the family member to monitor the sign of relapse, especially if the patient starts to sleep late at night or sleep less, and starts to show the talking and laughing to himself or herself, or there's a total or gross self-neglect, for example, poor self-hygiene. And very important for the family member to look at the signs of danger. If the patient starts to show some aggressive behavior at home, especially easily become irritable, start to shout, and the other signs of relapse, uh, which the patient needs to be brought to hospital, especially when they starts to show aggressive behavior to the self or to others. And also very important to advise the patient and family member to come for the follow-up to maintain good health practices, or a healthy lifestyle, such as they need to make sure that they have enough sleep, they need to avoid alcohol and also drugs or other substance, eat a regular or healthy diet, especially when they start to complain that they put on weight due to taking the drugs, and they need to exercise regularly. And it is also important for us to inform about the supports available in the community, especially for the psychiatric care. So for the psychosocial rehab, we have Pusat Kesihatan Mental Masyarakat, in short we call it Mentari. So certain klinik kesihatan provide this kind of services for the daily basis for the patients to come daily and join the activities. And we also have community psychiatry and home care psychiatry. So the patient and the family members can ask if they are suitable or eligible to be enrolled in this community psychiatry or home care psychiatry. Okay, that's all for schizophrenia.